Hi guys, the topic that we're studying is pulmonary alveolar proteinosis. The fundamental problem in this condition is that surfactant is produced but it is not degraded. You see, the surfactant will do its routine job, lowering the surface tension, preventing alveolar collapse. The function is going to be fine, but then it's not going to be destroyed. So it will continue to accumulate in the alveoli of the patient. It will cause obstruction. It will result in decreased gas exchange, which will explain the symptoms of dyspnea and exertion that will develop in this patient. And later on, the amount of surfactant that is produced is normal, but because the degradation part is affected, it will accumulate even in the respiratory bronchioles, terminal bronchioles, and sometimes might be even cuffed out in the sputum of the patient. In fact, the question might say chunky, pink, gelatinous plugs which are being cuffed out by the patient. Like in asthma, you read about Cushman spirals being cuffed out by the patient, especially after giving bronchodilators. In this condition, I'm saying the person would be coughing out what is present in the sputum is actually chunks of surfactant which have not been degraded. So let us now study what is going to control this degradation part and which cell is malfunctioning. You see, you are aware of the composition of the surfactant, that is dipalmitoyl phosphatidylcholine, and along with this you have some surfactant proteins as well. The surfactant proteins are themselves of four subtypes, that is A, B, C and D. Per se, in this condition, the production of surfactant proteins is fine. But then there is a production of a cytokine by the name of GMCSF that you study in hematology by the alveolar macrophages. At this junction, I also want to highlight before you that the main function of alveolar macrophages will be to function as a security system, but then they also play a role in actually degrading the surfactant. Well, GMCSF is produced by the alveolar macrophages and then it will degrade the surfactant. The problem in this case, if asked in the MCQ specifically, would be that the bioactivity of GCSF is lesser. This means that the macrophages are doing their job properly. At least the amount of GMCSF produced is fine, but then the bioactivity is relatively lesser. So there's going to be reduction in what I said right in the beginning of this discussion, or reduction in the degradation of the surfactant. It keeps on accumulating in the airways. It will obstruct the airways, and in later stages there would be even concomitant pulmonary fibrosis. So there would be a restrictive lung disease developing in the patient. I would like to highlight that initially the surfactant is obstructing the airways. It will fill up in the airways, but later there would be a definitive pulmonary fibrosis coming up as well. So later part of the disease, you will be having a restrictive pattern on spirometry. In fact, I can just make you remember the same information in the following fashion. We can take this to be the representation of terminal bronchioles, then the respiratory bronchioles, then the gas unit, that is the alveoli, and well, you have these blood vessels where the gas exchange would take place. In this patient, I'm using a pink color to highlight the surfactant. The surfactant is produced, it's going to line the alveoli, but then the problem is that the amount will keep on increasing. So let me make you practice with the help of a diagram so that you can remember this information relatively better. You can see terminal bronchioles, respiratory bronchioles, alveoli, which are going to be responsible for gas exchange. These are the blood vessels. And the bad news is that in this condition, the surfactant that I'm showing in relatively pink color, it's going to line the alveoli initially, but then it's not going to be degraded, so it's going to fill up these airways. You can see the pink is the representation of surfactant which is filling up the airways. It is obstructing the airways and would be coughed out by the patient as well. So the usual query that will come up next will be, why is it happening? Well, it could be congenital, it could be acquired. Most of the time in the MCQ, he might give you a congenital scenario and might actually tell you that the sibling brother or sister of this child died due to lung disease. He may not specify what is the lung disease, because then obviously the question becomes a piece of cake for you. But if he mentions regarding death in the sibling due to a lung disease right in the first year of life, you definitely have to think in terms of either cystic fibrosis, right, recurrent lung infections, or pulmonary alveolar proteinosis as well. So it's just added to the list. Lung disease contributing to mortality in the first year primarily in infantile age can either be cystic fibrosis, recurrent pneumonia, or PAP per se. The pattern of inheritance is autosomal recessive. Second, he can actually mix this up with the occupational lung disease. Studies have shown that people who are into construction business, people who work in the glass industry, people who are having occupational lung diseases like silicosis, which he may not write the word silicosis, he might just say exposure to inhalational dusts due to occupational reasons. And this can also be a trigger which can result in decrease in the bioactivity of GMCSF, as a result of which the degradation surfactant is hampered. The remaining two conditions are relatively rare. One of them is lysinuric acid intolerance, and then even association with hematological malignancies. In fact, in place of the word hematological malignancies, he can write the word LRM, which basically stands for lymphoreticular malignancies. Well, once we know the causes, we know the triggers. Let's now look at how the patient is going to present to us. And most of the questions that would be given in this case might be misdiagnosed by you in the exam as a case of occupational lung disease, because the moment he talks about a construction worker coming to you with complaints of breathlessness at rest, the first thought process is this is a pneumoconiosis. If the history of death in the sibling is given, great. Even if it is not given, I'm going to describe a case of a 30 to 50-year-old male. Because why I'm saying male is because, you see, when it comes to occupational lung diseases, I mean, men are the one who are mostly going to be found working in a cement plant, construction business, or let me say a glass industry. There is one more industry I want to highlight here. You see, rock blasting. What I mean by rock blasting is that they drill holes in the rock using a drill machine, then they fill dynamite inside it, and then they blast the rocks, and those rocks are then used for construction purposes. Now, when I say the word rock, then what should come in your mind is crystals of quartz. And these crystals of quartz, when they go in the lung, they can definitely cause occupational lung disease and can even trigger pulmonary alveolar proteinosis to occur in a patient. The question will begin by describing this chap with occupational history having breathlessness on exercise. The person feels tired most part of the day, so he might be taking frequent offs, or absenteeism would be present from his job, so he might be fired from his job as well. And then he's going to describe features of weight loss, which are traditional with most of the lung diseases, and fever. So there is a distinct possibility that you might be tempted to think, is this a case of pulmonary tuberculosis, because that's a much more common disease in our country. What you will notice will be a very characteristic statement which will be given in the question, and I highlighted this earlier as well, that in the sputum of this person, this surfactant will be coughed out. Imagine, I mean, it's been produced since birth, it's not getting degraded, so it fills up the airways to the level that now it's going to come in the sputum of the patient. So whenever you read this statement of mine, chunky gelatinous sputum plugs, and the thought process of yours when you read this would be that, well, this condition where these gelatinous sputum plugs are present are akin to, I would say, akin to what you read as Cushman spirals in a case of bronchial asthma. Those are actually the casts of the airways, and anyway in asthma also there is excessive sputum production. So initially my thought process is either it is occupational lung disease, it could be pulmonary tuberculosis as well. So let's now look at the workup that will be done in this case, and obviously the HRCT will be helping you in the diagnosis, but alone HRCT would not be making a diagnosis. Let us now discuss regarding the workup of this patient, where HRCT will definitely aid you in the diagnosis. The first test that I'll be doing in this guy is a pulmonary function test, which will be showing a restrictive pattern. I have highlighted already that restrictive pattern implies that timed vital capacity to be given in the question could either be normal or could be increased, whereas it's always reduced in obstructive. The chest X-ray of this person can be revealing a snowstorm pattern. Snowstorm pattern per se on a chest X-ray is itself a MCQ that our examiners love to ask you so many times. In fact, even if you're going for a job interview, it's no big deal that they might give you an X-ray that might be having a snowstorm picture, and then they might ask you to enumerate causes of it. One of the important causes is pulmonary tuberculosis, then can be occupational lung disease, the commonest one in India, that is silicosis. Then is chickenpox pneumonia. I mean, the causes that I'm going to explain before you are the ones which are important from exam perspective. There are a total of 5 important causes of snowstorm appearance on chest X-ray that should be remembered, including fat embolism syndrome and the current topic of interest, that is PAP. This information that I've written in color black before you is something that you're not supposed to forget unless or until you get into a PG seat and you start taking up or start doing specialization. If you're applying for junior residency anywhere, no big deal that this is a very common X-ray scenario that can be asked to you in a non-academic JR post. Now, the next thing that we are going to do in this guy is a HRCT with the classical finding of crazy pavement pattern. I'll just show you the image also. But as I said, I mean, crazy pavement pattern can be present in multiple other conditions also. So alone crazy pavement pattern will definitely not help. It's a combination of all the findings that I'm highlighting. Please remember that the reason for crazy pavement pattern is a thickened interlobular septa. So instead of writing crazy pavement, which will make it easier for you to crack the question, he can actually write this terminology as well. In fact, sometimes in the X-ray of this patient, he might actually use the word bat wing infiltrates. Now, I did not use the word bat wing edema. I just said bat wing infiltrates can also be written, and obviously because they are diffusely present, so the word snowstorm would also come up. The best test for confirming the diagnosis of this question per se, I highlight this fact, guys. Point number 4 is the most important finding that I'm going to teach you for this particular topic. The best way for confirming the diagnosis of pulmonary alveolar proteinosis is to go in for a bronchoalveolar lavage. We do a bronchoscopy, we do a lavage, and once we have done a lavage, we will be able to demonstrate a Schiff's reagent, that is PAS positive lipoproteinaceous material, which will be present in the lavage. That's the key word that I want you to remember. I mean, unless and until you read this statement, PAS positive lipoproteinaceous material found in bronchoalveolar lavage, you are not supposed to comment on the diagnosis of pulmonary alveolar proteinosis, however tempting it may look. Now, when it comes to PAS per se, you are anyway familiar that if we are talking about a question of liver cirrhosis with emphysema, then PAS positive inclusions inside the hepatocytes can be seen with alpha 1 antitrypsin deficiency. PAS positive inclusions in GI tract have been discussed for Trophairma whippleyi, that is Whipple's disease per se. So I'll summarize 3 times when I've talked about a PAS positive report. That's going to be for bronchoalveolar lavage, then is going to be for alpha 1 antitrypsin deficiency, the inclusion bodies in the hepatocytes, and then in the small intestinal mucosal biopsy, a deep-seated, there would be macrophages inside which Trophairma whippleyi is hiding, and it can be stained with PAS. Let's look at the images now, guys. You see the way you appearance would look, it's like, marble flooring, or I would put it like this, tiles, when tiles are put. So that's why the name that is given here is very characteristic, the crazy pavement pattern, because of the pattern of tiles which is present, and is not to be confused with what you can see as whitish opacities. And in fact, this is what examiners would definitely like to trouble you with as an additional question, that is ground glass opacities. Ground glass opacities is what you encounter with respect to, at the moment, I mean, COVID-19 can also be having ground glass in the later stages, but ground glass opacities is one very characteristic that you read with interstitial lung disease. And lastly, it comes to the treatment of this condition. And then again, I'm going to say very surprising thing that like you get servicing of your car done every 6 months, 1 year, you get a washing of your car, you get cleaning of your car engine done on an annual basis, let me say. Here we will have to clean the lungs of the patient. Look at the surprising thing that I'm telling you, whole lung lavage. I mean, first time when you introduce this to a patient, the patient is literally in a disbelief. He says, sir, you're going to wash my lungs? Yeah, we definitely going to do that, because we need to remove all that surfactant which is stuck up inside your smaller airways. So whole lung lavage is the treatment of choice for pulmonary alveolar proteinosis. The 3 concepts that you need to understand for this topic is point number 1, GMCSF bioactivity is lesser. Amount wise is normal. It's not able to degrade. The symptoms can be mimicking that of pulmonary tuberculosis as well as interstitial lung disease. That is why we're going to do pulmonary function testing, we're going to do X-ray, we're going to do HRCT, and finally, we are going to do a bronchoalveolar lavage. That's the second point. Investigation of choice, treatment of choice, whole lung lavage. 3 points, guys: GM-CSF bioactivity, the lavage part, and the whole lung lavage. If you get these 3 right, then the remaining information will definitely fall into place, because from the history perspective, if you remember this statement of mine, which is akin to Kurschman spirals, if I was talking about an asthmatic patient and then he's having this sputum plugs, especially after giving bronchodilator, you will say Kurschman spirals. Similarly, in the same spirit, I want you to remember, if he talks about a child or adult involved in construction business and having these manifestations, then pulmonary alveolar proteinosis would be the first one on the radar for you. These are the details to be remembered for this topic. Keep learning, guys. Keep hammering. Thank you so much for hearing me out.